Okay.
Okay.
So I haven't talked about bipolar disorder in itself. So it's actually three times as common as schizophrenia. One example that you have heard is Jack, the musician who threatened to kill his girlfriend and hang the pieces of her body on the trees. He was typical of people in the manic phase of bipolar disorder. He was a professional musician with a band, very high functioning till he got sick. Then he was like a person on a run of amphetamine abuse, first euphoric, grandiose, and high energy, and then verging on psychotic. After a couple of months of treatment, he was back to his usual self. He went home and broke up with his girlfriend over the phone, got his place back in the band, and went on as before. So, next, I'm going to talk about the prodromal signs of schizophrenia. I think we talked about a little bit of this. And anyway, if I'm repeating, let me know. So, these are the signs, and there are a lot of them that a full-blown schizophrenia um, might be happening, yeah. Anyway, these are the prodromal signs. First, unusual thoughts or delusional ideas, feeling persecuted or suspicious of previously trusted friends or family, an exaggerated feeling of self-importance, perceptual abnormalities, e.g., seeing flashes or fleeting visions of animals not seen by others, or hearing sounds that others don't hear, like phones ringing or sounds on the roof, disorganized communication, having trouble making oneself understood, and having difficulty following conversations with others, loss of pleasure in social activities, feeling unhappy being around others, difficulty at school, general withdrawal from family and friends. And all these, I think could be signs of depression, actually. So it's not necessarily leading to schizophrenia, but they're among the things that are seen. Odd behavior and appearance, bizarre thinking, decreased personal hygiene, decreased functioning at school or work, trouble with focus and attention, difficulty sleeping, general inability to feel pleasure, and difficulty coping with normal stress. What's not on this list is anosognosia, the inability to see that they're sick, which usually starts a little later. But this is why I start. Go ahead. Was there some, did somebody say something? Oh, okay. This is why starting treatment early in the prodromal phase is so helpful because people do feel like they're sick and so they're open to treatment. So I'm going to talk about the Dry Valley Service Center. In 2018, I pushed all my private practice patients into 2 long days and went to work at the Dry Valley Service Center in East Oakland. The area had a reputation for being dangerous. The week before, there'd been a shooting in the parking lot. Lauren, my new boss, was alarmed when I told her I'd parked in the parking lot, and she dropped everything and walked me down to the underground parking lot right next to where the police parked their cars. In the clinic, the receptionist sat behind a bulletproof glass. We had a sheriff's deputy, fully armed, stationed at the clinic. Most of our patients were Black, also most of our staff. Dry Valley is an FSP, a full service partnership, said to be, quote, a hospital without walls, unquote. So just as good as hospital care, but without a hospital. In reality, it was nothing like a hospital. I had more than 100 patients, and many of them I was never able to see. Nobody could find them. The others I saw in their board and care homes or in the clinic, if they were able to make it to the clinic. Sophie, the nurse practitioner who was leaving that I was replacing, had 2 file drawers full of patient files. She told me that we weren't supposed to keep those records. They were called the shadow files, quote unquote. We were supposed to destroy them after we put them in the fiche. I'll show you, she said, the fiche. She opened up the fiche on my computer. It showed a random scattering of file pages floating against a blue background. I looked at her in amazement. You really put records in this fiche thing? She closed the screen. I'll help you move the files. The official medical records were restricted to our clinician's gateway file in the computer. The clinician's gateway was like a Procrustean bed, a rigid format that began with a diagnosis of schizophrenia. You couldn't change that to match the reality if your patient didn't have schizophrenia. The reason was that insurance paid the most for that diagnosis. I talked to a friend, an ER doctor, about this awful system. Oh, yes, he said, we do that all the time. It's called upcoding. You couldn't accurately report basic things, such as where you saw the patient or for how long. The computer program would only report 25 minutes seen in the office. One day, I went to a patient's board and care home to see him because he wouldn't come to the clinic. When I found him sitting alone in the common room, he turned away to stare up into the corner of the ceiling, looking terrified. He couldn't bring himself to look at me. I imagined he was being assailed by vicious voices, made unbearable by my presence. It was so clear that he was unable to tolerate this interview that I cut it short after a couple of minutes. But on his record in Clinician's Gateway, I couldn't report what actually happened. I had to leave it at 25 minutes in the office. A total lie. We all knew how pointless these medical records were for patient care. The worst thing about it was that every time you saw a patient, you had to spend as much time at the computer as you did with the patient, filling out the long, long computer record, the same every time. When my friend Susanna, one of our most diligent case managers, decided to quit, she said, "It's the hours and hours on the computer, and no one reads those things anyway." I remembered a note I'd read from a patient who'd been at Santa Rita. It began, quote, "Patient seen at his cell door." It told so much. Patient in jail, interview not private. But the chart at Santa Rita was not for billing, it was for medical care, because Santa Rita has no need to lie in their medical records. It's funded by the state. Toward the end of my time at that clinic, we were given a new instruction on charting, already time-consuming and nearly useless. It was 20 pages, single-spaced, a list of terms that we were not to abbreviate, some medical terms, others everyday expressions like 24/7. It would hugely increase our charting time. And why? I wrote to all the bosses at every level. Why couldn't we just give this guide to the people who were evaluating our records? Nobody could tell me. Later, I got a clue. It turns out that insurance companies, and certainly Medi-Cal, were using AI to evaluate claims. We do need all the information we can get to adequately assess our patients and learn what's been tried in the past, what worked and what didn't, what meds were useful, and other things such as level of function, work, and social history, and medical history. Today, that information is often nowhere to be found. We operate as if we can spend 15 minutes with a patient with nothing more to help us divine what the problem is, like what treatment has worked in the past, how the patient is done before coming to our office. Obviously, this is not true. If the patient has been treated before, we need to have the correct diagnosis or diagnoses, or what's been considered the differential diagnosis. We need to know what meds helped or didn't help. I think this is a little repetitive, sorry. Back in the day, before medical records were computerized, we wrote our notes on paper. For hospital care, a long note at the beginning, the history and physical, and at the end, the discharge summary. Those two notes we dictated, and the typed copy was filed in the ongoing chart. You could look at old records and learn much of what was important and take it from
Alice,
there. Yes.
when were you at Santa Rita?
What? Oh, I
When?
wasn't at when.
Yeah.
That was just a note. It was just in the records, it was a note on a patient.
What time period are we talking about here?
Uh, that's a good question because I don't remember the date. I mean, it was 2018 that I was reading it, but it wasn't, you know, I don't remember the date.
Yeah.
Sorry. Are there other questions? Anything people want to say at this point? Okay. It
Alice,
seems that when,
I want to
yeah,
say something quickly.
yes,
finished your book
Yeah.
last night and called my daughter and I said, "Did you know that robots are reading these claims that," and she went in for a simple thing with her eye, some kind of a sty that was growing on her eyelid, and they ended up charging her something like $4,000. And they claimed all this stuff. They claimed they did it twice. The hospital was claiming it once, and the office was claiming it another one. And I said, "You've got to fight this because they're just going to do it as long as they can get away with it." So it was really helpful to know that computers are reading these things and that you need to fight all the claims.
Yeah. Yeah. Well, that's a sort of a horrifying story, but anyway, very, very, yeah. Okay. So where's my script? Okay. Uh, so it seems that when our records were computerized, they were no longer to be used for treatment, but simply for billing. The exception to this is in a single payer system. Occasionally, we hear a call for a single payer, a system that eliminates billing. It's said to be the same as Medicare for all, but Medicare still requires billing for each service. So that's fee for service. Single payer eliminates billing altogether and pays medical staff directly on a salary basis. With single payer, the medical staff spend their time based on need for care, whether it's brief or very complex. It's economical because it cuts out private insurance companies, which require huge amounts of time on billing chores and follow-up on non-payment. With fee-for-service, insurance-based, we clinicians must stop after every patient encounter and write the long note used only for billing. Imagine if a carpenter had to stop his work after every piece of lumber hammered into place and write out a long document detailing things like the number of nails used. Or if a chef had to stop her work and document number of eggs used, slices of bread, and other details for the purpose of billing. No one would stand for it. But we employ whole armies of billing staff dedicated to this chore. And in our notes, we are forced into upcoding, like with my clinic patients who are always diagnosed with schizophrenia. Single payer frees up the clinician to be truthful. We can write what really happened. We can document our thinking, such as a differential diagnosis, if we're not sure what ails the patient, and the follow-up to pin down the diagnosis or diagnoses, such as depression and cocaine dependence. Another thing with the insurance-based system is we never were allowed to talk about drug use, drug abuse or addiction as part of the cause of illness. Apparently that canceled insurance payments. Anyway, so single payer, frees us up to be truthful, as well as a response to treatment, which is really important to guide our thinking. Other countries generally use single payer systems, and right here we have at least two large systems that employ a single payer method. Kaiser and the VA, both of which I've worked in, maybe others as well. When we were hiring to fill two new positions at Kaiser, we were flooded with excellent candidates. I realized that Kaiser was seen by doctors and other clinicians as a good place to work. The ability to focus on patient care, write truthfully in the medical record rather than lies for billing, and to have useful medical records as well is a blessing. Communication is important to what we do. Without useful medical records, we rely on other staff, i.e. the case managers. At the Dry Valley Clinic, we had hundreds of patients, one or two psychiatrists, and about 20 case managers. Some of the case managers were diligent, others were MIA. Chloe was the perfect case manager. She stood in my open door at the end of each day and gave me a rundown. Yes. What? Did somebody
That's
have a
just
question?
McAtee's.
Hi, McAtee.
Oh,
Okay, let me just.
Go
Okay.
ahead, Alice. He's just.
Yeah,
I'm in.
I know. I'm trying to, okay. Uh,
Sorry.
No problem, no problem, just to get on the right screen. Uh, Jesus, sorry. The problem is that I need to be able to get back to the, okay, well, anyway, Chloe was the perfect, so Chloe was the perfect case manager. She stood in my open door at the end of each day and gave me a rundown on all the patients we shared. One day she mentioned Morgan, and I interrupted her. He told me he's not violent, I said. She came in and shut the door. He spent 10 months in jail for assault, she said. I'd forgotten that. Morgan was a gentle giant. I couldn't imagine him being violent. But the next day, she got me out of a meeting to let me know that Morgan's board and care operator called to tell her that he was acting weird, scaring her. Chloe got on the phone and asked Morgan, Jesus, sorry. Okay, sorry. Chloe got on the phone and asked Morgan to come in and see us. He came, but he was acting weird, baring his teeth and twisting his lips from side to side. My roommate stole my clothes, he told us. I'm going to light him up. When we got the sheriff's deputy to do a 5150 assessment on Morgan. He judged that Morgan was not holdable, but we told Morgan to go home and come back with all his meds. It turned out that Morgan decided the meds were causing him to gain weight, which is common. I stopped the Zyprexa, which does have that effect, and gave him a different antipsychotic. And after that, he went on getting better. Chloe was unusual. She talked with me every day, and she talked with the board and care operator who knew that she could call Chloe for help with Morgan. A few case managers are like this, and it makes all the difference. So when we went out to make house calls, Chloe would give me a plastic seat cover from a supply in her trunk. She wouldn't let me sit in the car till I'd covered the passenger seat. 90% of the social worker's job is protecting against vermin, she told me. Bed bugs, head lice, and scabies were a constant worry. Board and care homes are often infected with one or another. Then every resident of the house had to be checked and cleared before they could sit in our waiting room or come into our offices. Patients were cleared by the beloved Dr. Jones, a family practice doctor who worked with Good Hope Medical, the clinic that shared our waiting room. We'd been trying to find a way for me to see Sammy, who lived in a board and care home infested with bed bugs. Chloe told me I should meet with him out on the sidewalk so as not to contaminate the clinic. He'll be fine with it if you tell him we're concerned he might give us bed bugs, she said. I couldn't imagine that Sammy would be fine with it, that he'd be happy to discuss his mental illness outside with strangers walking by as we talked, much less that he'd be fine with it if we told him we were afraid he might give us bed bugs. In the end, we met with Sammy over the phone, Chloe's cell phone on the table between us, and Sammy sitting at the board and care operator's desk, which meant the operator had to vacate her office while we met with Sammy. Chloe wanted to send a message to her. Hopefully, she said, this will give her a nudge to get the house certified bug-free. We shared our waiting room with the Good Hope Medical Clinic next door. Aisha, the Good Hope clinic administrator, would send us spreadsheets with updates on which homes were infested with which vermin, which homes cleared, which patients were cleared or not yet cleared. Aisha was a miracle of tact. Tall and elegant, she guarded the waiting room chairs with their fabric cushions, tipping the suspicious chairs against the wall. She even took on the problem patients, like the guy who sat very close to the young men in the waiting room and put his hands all over them. Aisha joked with him as she moved him to a distant chair. You know you can't sit there, she laughed. Coming from her, it sounded like love. When I first came to Dry Valley Clinic, Bjorn was among my many patients Sophie had told me about, but I didn't remember his history. So as I got ready to see Eric Bjorn, I quickly reread my note from Sophie. 28-year-old man, suicide attempt at 6, jumped off parent's roof, long history of violence, 5150 multiple times. In 2015, 3 years earlier, assaulted man with crowbar, charged with attempted murder, IST, incompetent to stand trial, Napa 1 year, Sierra briefly, then, quote, lost funding, unquote, and sent him to us. We had the sheriff's deputy. I put on my most non-threatening face and came into the waiting room. It was empty. The receptionist behind the bulletproof glass nodded at the door to the other clinic. We shared the waiting room. Eric was next door watching TV. On the screen were huge men in a boxing ring wearing costumes. As I got close, Eric closed the screen and followed me silently back to my office. He looked like an overgrown teenager, round arms and pale, wispy hair. I said, "How you doing?" He said, "You have my name wrong. The people who gave me that name, they stole me from my real parents when I was a small child." I said, "Goodness, what's your real name?" "Neil Mascaris." I said, "What?" "I'll spell it for you." I pushed my writing pad and pen across the table to him. He said, "Meal Mascaris, 1,000 masks. You have my name wrong in your computer. You need to change it." I said, "I can do that." But I wrote it in the first narrative box and left the name unchanged. Then he did what no patient had ever done. He came around behind me and looked over my shoulder, saw that I'd cheated, turned and walked out the door. I went right after him, trying to keep up as he strode down the hall and banged his way through the outside door. "Sorry," I said. "That was disrespectful. Can we try again?" After more of this, he came back. This time, I changed his name properly, tipped the screen around to show him. "So," I said, "the people who stole you, did they treat you okay?" He said, "Them? I guess so." I thought, so this didn't sound like trauma or child abuse because these people just sounded so vague. I said, "Good. So tell me about yourself. What should I know?" He hesitated, then pulled out his phone and showed me a picture of Mil Mascaras. He was a lucha libre, a Mexican fighter in a costume. He wore a mask that enclosed his entire head, a raptor with its beak open as in a terrifying shriek. That was the last time I saw Eric. When he no-showed for his appointment 3 weeks later, I called the board and care operator. She told me that Eric had discontinued his meds. She said it in a lighthearted tone of voice. The first week was bad, but the second week was better. I was appalled. This was a young, strong guy who'd almost killed another person in a fit of rage. But she was unconcerned. Eric's case manager was unconcerned, as was our clinic director and the other psychiatrist there, who turned the topic to trout fishing. I never saw Eric again, but I've always wondered about him. So this is another patient I saw at Dry Valley. Carrie was a Vietnam vet who had been living on the streets for years. When he first came to my office, he chose the chair furthest from the door, and I wondered about PTSD, as he was a combat vet. But he tipped his chair back against the wall and recounted his adventures in Vietnam, courage under fire, close calls. Now he lived on the streets. "I've been homeless by choice since 1965, he told me. "I thought you were in Vietnam in 1965, I said, a little worried that I might be bursting his bubble. But he said, "Oh yeah, 1975, and went on unperturbed about the life of freedom he enjoyed with his friends on the street. But then Marla, a young social worker, pulled off a coup. She found a one-bedroom apartment for Carrie. The next time I saw him, he'd moved into his new apartment. All his bravado was gone. He sat by my desk and stared into the middle distance. He had a haunted look, as if he'd just witnessed a massacre. He said, "I've got a living room and a kitchen and a dining room table." I said, "How is it having your own place indoors?" He shook his head. He still hung out with his friends, he said, "but then it's like, see you in the morning," and I go up to my nice warm bed. The next day in rounds, we heard that Carrie was still depressed. Marla had tried to get him to go to the senior center so he could have some social life, but he wouldn't go. Could Dr. Feller do a phone interview? She asked. Why couldn't I just go over and see him? I asked. I could see it would be a problem, but I couldn't understand why. I can't see him over the phone, I told her. Marla seemed dubious, but she agreed to meet me at the apartment. It was a concrete building, gray and cold. When we knocked on the door, Carrie appeared and graciously invited us in. Marla asked if I was sure I was okay without her. I was sure. Carrie was subdued, a far cry from the jolly old soldier who tipped his chair back and told war stories. It seemed he was overwhelmed by the task of coping with my visit. On the dining room table were all the bags of supplies Marla had gotten for him, all unopened. I asked if I could look at the bags, and when I got to the bag from CVS, still stapled shut, he apologized. I said, "That's okay. Can I open it?" It contained the small bottle of Zoloft I prescribed. I knew he wouldn't take it, but Marla insisted. He continued to come to my office for his appointments, always the same heartbroken guy. But one day he came in and sat in his old place against the far wall, chair tipped back, telling me his latest adventure. He'd gone out with his crew on the street, as always, but this time they ventured into new territory. The police were called. They rounded up the homeless intruders and threatened them with prison if they ever came back. It was not a gentle warning. But finally, Carrie was truly one of the gang again. This is another young man I met when he was 26 years old.
Can
His
I
name is, yes,
stop you
yes,
just a
yes.
second? I'm interested
Yeah.
because he was a vet. He wasn't able to get care through the VA, or that wasn't he didn't want care through the VA.
That's such a good question. I don't know.
Oh, because
I never thought about that, actually.
my
Yeah.
my brother-in-law, Dan's younger brother, is bipolar, and he was in the submarines in the Navy for 6 years. Then he had his first experience with that when he was in college at Yale afterward. And since then, he's received his care through the VA, and I have been really impressed. He now lives in, he went to law school after that, and he now practices sort of a very small scale community law in Kansas City. But he's occasionally had problems. Dan goes, and his older brother, I think, occasionally, I mean, or helps when his older brother lives there. But the VA has just been extremely impressive in the care they've delivered, their organization, and the coordination across different units of the VA. So if he shows up at the care where he gets for diabetes, then and there's an issue, then they trundle him over to the mental health section, and
Yeah.
they seem to keep track. So it seems as if someone like this would really, and as you said earlier, single payer,
Mhm.
the VA. But anyway, I was impressed with the VA, and it seems rather sad that somebody didn't have access to such improved care.
Yeah, it is. And thank you for mentioning that because it never occurred to me. Um, I know that not every vet gets to have VA care, but I'm not sure what it was with Carrie. Yeah. Um, I worked at the VA for a couple of years. I did a 2-year fellowship in substance abuse. The VA was recruiting not psychiatrists to do that because they had so many veterans coming home from Vietnam addicted to heroin. So, okay. How do I do this? Okay. Oh, I see. Jesus, sorry about that. Okay. So, Brandon. When I first met Brandon, he was 26 years old. His case manager, Chloe, told me he'd been irritable, withdrawn, and shut down. But he sat across from me and gave me a shy, sort of embarrassed smile. He confessed he'd blown it again and was about to get kicked out of another board and care home. Too much weed, he said. I laughed. How much is too much? He smiled and seemed to consider. We only get $5 a day, 2 days out, 2 days in. The same problem with meth, he added. His allowance would buy 5 days' worth, which he'd smoke in one day. I hadn't quite followed this, but I wasn't going to interrupt because while he was telling me about his drug use. I thought of the terrible withdrawal that follows a run of methamphetamine. As if his thoughts ran on the same track, he said, I was in John George. I knew that he'd just been hospitalized there for depression with suicidal intent. They found a click in my thinking. Neither one of us knew what that meant. I wondered if he had a thought disorder or if he was just confused by the THC and possibly from cocaine withdrawal. I've been homeless before, he told me. I want to do it again. His face was full of longing. Before she left, Sophie warned me that Brandon, quote, failed to bond, unquote, with his first two case managers and was on his third now. And I remembered her earlier warning. He's very enmeshed with his mother. It caught my attention. My coworkers didn't usually use jargon like enmeshed and failed to bond. But Brandon seemed to inspire an unusual interest in his psychology. As I made a return appointment with Brandon, I found myself worrying about whether he'd show up for it. I very much wanted him to like me and come back to see me. After he left, his case manager told me that he left our meeting elated and signed all the forms without resistance. When I heard this, I relaxed. We were drawn to him, all of us. He had a different effect on us than what we were used to. He inspired a kind of longing in us. His diagnosis was disorganized schizophrenia, but I didn't think he had any kind of schizophrenia. He didn't seem delusional, just confused. Also, antipsychotics never helped him, even in large doses. And he had other reasons to be confused. Meth would do that. Marijuana would too. I wanted to know what he was like off all his drugs, prescription and street drugs. I thought we should stop the antipsychotics, but what if we did and he got worse? There was one hope. He spent 6 months at Sierra Sunrise, a locked step-down facility that had a good reputation. Sunrise could tell us all we needed to know. His doctor would have taken him off his meds and let the street drugs leave his system. There'd be useful nursing notes and notes from therapists who'd seen him. Ideally, a discharge note from his doctor. But when I asked Sophie what we did to get records from Sierra, she said, we don't get them. I stared at her. Why not? We just don't, she said. I couldn't understand it, so I began a quest to get them. I called and left a message, called again, sent them the signed release from Brandon. Nothing came back. I called once more, and this time somebody answered, a woman who yelled at me for my efforts. Don't ever call here again, she screamed. Recently, I Googled Sierra Sunrise. I learned that it was run by a large corporation, a company that runs similar facilities around the country. They rely heavily on virtual visits between doctors and patients. I knew how that went. No doctor would have taken an interest in Brandon. Sierra Sunrise was not a hospital of any sort. It was a mental health version of a nursing home, but locked. When I asked Brandon about his stay there, he said he watched TV and slept. The last time I saw Brandon, he told me he wanted to be homeless again. I want to fit in and be happy with myself, be part of where everything is, where I don't feel so lonely. Brandon was kept on antipsychotic medication, regardless of the fact that it didn't help him. I was sure that he wasn't schizophrenic. As a teenager, he'd had a bicycle accident that knocked him out, and it took several minutes for him to regain consciousness. After that, he changed. He'd go out late at night and come back smelling of marijuana and alcohol. He set off a firecracker in class one day and ended up in juvenile hall for a month. At the end of that month, he'd added crack cocaine and heroin to his drug use. He would become suddenly suicidally depressed and was hospitalized a couple times for that. My guess is that he suffered from drug addiction. We wouldn't know if his depression was a result of his drug use until he spent time free of drugs, but that wasn't about to happen. This is called Turned Away. Lucille. The last time I saw Lucille was right after Christmas, and she glowed with her good news. For the first time since he was 10 years old, she'd gotten to see her son, now 24. Lucille was 13 when he was born, 2 years older when she had her second son. Her brother took over their care, and Lucille was kept away. Now Lucille lived in a board and care home. She was a black woman who seemed much younger than her real age, which was 37. She liked to watch TV and eat. She was cursed with a serious mental illness, probably schizophrenia, and it took multiple medications to keep her free of her demons. We'd gone over her medications just before Christmas to weed out the worst ones, the ones that cause massive weight gain. We weigh our patients to guard against this problem and its evil twin, type 2 diabetes. When we met just before Christmas, she watched me slide the weights along the balance, the resulting number a new high. Her face crumpled. She told me she ate a second dinner before bedtime while she watched TV. But as she talked, she decided she didn't need that second dinner. When we met again after Christmas, she stepped on the scale and we saw that she'd lost 10 pounds. She was ecstatic. Life seemed very good right then. That was the last time I saw Lucille. I was away for 3 weeks in February. When I returned, I heard the news. Lucille had gotten into an argument with her board and care operator, accused her of being racist, and left home. After living on the street for some days, she went to the closest hospital, San Geronimo, and told them she couldn't breathe and was passing out. The physician's assistant who saw her wrote that Lucille had a urinary tract infection, also bipolar disorder and schizophrenia. She gave Lucille a prescription for an antibiotic and a list of homeless shelters. The next day, Lucille came back with the same problem but worse. She was so short of breath that she had a hard time speaking more than a few words. She was seen by 6 clinicians in the ER, all of whom noted first her incontinence, which was thought to be chronic. They noted her psychiatric diagnosis, but complained that she was, quote, a poor historian, unquote. Nobody seemed to notice her severe shortness of breath. However, after 2 days, she was admitted to the ER and a CT angiogram was done. The radiologist documented the time and date of his call to the ER doctor with results. The angiogram showed, quote, extensive pulmonary embolism, i.e. blood clots throughout her lungs, a collapsed lobe on the right lung, and an enlarged heart. No wonder she was short of breath. When we heard the story, all of us said the same thing. If that were you or me, we'd be in the ICU. Instead, Lucille was sent out with a bus ticket and told to make her way to Highland Hospital. Usually patients who are dumped at Highland get the courtesy of a taxi ride to that hospital. Lucille didn't even rate that high. It was February, and Lucille was dressed only in hospital scrubs. She never made it out of the parking lot. Later that day, a passing EMT crew saw her face down in the bushes and brought her body to the San Geronimo ER, where she was pronounced dead. We held a little memorial for Lucille and Renee, our 2 patients we lost. I spoke about Lucille and how she'd died and said I wanted to pursue it. My colleagues shook their heads. That would violate her confidentiality, they said. Her family had to do that. Her family was probably notified of her death, but certainly not how she died. They would do nothing. Today, we depend on board and care homes to care for our patients, many of whom are lost to psychosis. The board and care operator supplies food and shelter, beds, meals, and medication supervision. Most operators have turned over their own homes for this purpose. They're paid for their service, but not enough. They have to pay licensing fees that go up each year, and they could sell their old homes for many times what they bought them for. Today, twice as many board and care homes are closing down as there are opening up. But these homes are often what stand between our patients and homelessness. So I learned about board and care homes on a visit to see Violet. I went with her case manager, Chloe. We were directed toward the living room at the front of the house, down a long hall where the air was thick with a foul smell. Violet had the room to herself and didn't seem to mind the stifling air. She was a sharp-faced woman with a wild tangle of graying hair, half covered by a dirty watch cap. Her pants were ripped from her waistband down to her ankle on one side, revealing another pair of pants underneath. She sat in the center of a large white couch and didn't look up when we came in. Chloe introduced me, and we stood before Violet, who remained seated on the couch and seemed indifferent to our presence. She spoke in a loud, monotonous voice, a harangue, half preaching, half scolding. You go back where you came from. I got a baby here. No, 3 babies. I got 3 babies in me. She gave no sign of recognizing Chloe, who had been her case manager for the last 2 years. Finally, Chloe interrupted her. What happened to your pants, Violet? It's them rays, you know. What rays? From the aerospace ships. Her tone was knowing, as if she had special insight into things we'd never guess. I introduced myself and told Violet I'd be her new doctor. She waved me off. My husband, he's a psychiatrist, she said. He's in San Francisco. As an afterthought, she added, my other husband lives here. After that brief exchange, we went to look for Maria, the board and care operator. She lived on the premises and provided an unusual level of care to her clients. We found her in the basement, sitting at a large desk covered with papers. The air was cold, and she wore a frayed quilt jacket zipped up to her chin. Licensing is running after me, she said. I pay them more each year just to keep my license. For what? Chloe ignored this. We came to see Violet, she said. Maria made an exasperated sound. I can't keep the door locked at night because Violet has to sleep in the living room. Then she opens the door for anyone. Why can't she sleep in her own room? I asked. Because of the snakes. Snakes? The snakes the neighbors are dumping in the yard. She rolled her eyes. And the worms. She says her room is full of worms. The dim basement seemed to grow darker. She kind of smells, said Chloe. Don't I know it? She won't wash her hair. Maria paused. The worst of it is she doesn't use the toilet properly. Maria told us she'd taken Violet shopping and swapped out her filthy undergarments for new ones as Violet handed them out under the dressing room door. I had to kind of trick her, Maria said. She wanted to keep them. I wondered how Maria stuck it out there under such appalling circumstances and remained so devoted to her clients. The visit left me shaken. I had been away for a couple of weeks, and when I came back, the receptionist told me I should go talk to Lauren, the clinic manager. Her manner was grim. I went to see Lauren. Renee is dead, she told me. Renee was not my patient, and I wondered how this involved me. Then Lauren told me that she'd been killed by Abby, who was my patient. The clinic was alive with this story. Everyone was telling it, patients and staff alike. Abby and Renee had been bitter enemies. They lived at Sweet Dreams, a board and care home where patients had their own rooms. Abby's room was right next door to Renee's. 3 days earlier, Renee had come into Abby's room in the night, carrying a large knife. Luckily, Abby woke up in time to avoid being stabbed. Renee was an elderly woman who stumped along with a cane, and Abby was a young Samoan woman, about twice as large as Renee. Seeing the knife, Abby grabbed Renee's cane and whacked her over the head. Renee fell and didn't move. The floor was covered with blood. Others who lived at Sweet Dreams heard the ruckus and crept out to see what was going on. That's when they saw the knife come clattering down the stairs. Abby was arrested. Lauren had dropped everything to find her a lawyer, but the police questioned Abby without the lawyer. They went behind my back, she said. Now Abby was in a different board and care home. Lauren said, could you go and see her and see if she was mentally competent for that interview? So at the end of the day, I drove out to see Abby. Her new home was said to have a high level of security, but the door was open, so I went in. The high level of security turned out to be a sign-in sheet by the front door. I signed in and went to look for Abby. I didn't see her, but I heard her clumping down the stairs, calling, Dr. Feller, they said you were coming. She looked very odd. Her face was dotted with white goop. We found a place to sit and talk, and she didn't hesitate. I'm using this medicine for my chin hairs, she told me. Do you think it'll work? Maybe I should lose 10 pounds. She went on this way, and I was starting to get that fuzzy feeling I get in the presence of acute psychosis. For a fleeting moment, I thought maybe this wasn't Abby. I had only met her a couple times. Did the police come and talk to you? I asked. She waved that away. Oh, they're all done with me. Then she went back to her chin hairs. I drove back to the clinic and wrote a note documenting that Abby was not competent for a police interview. But the next day, the clinic was alive with a story. Our patients have little to offer each other. They're not allowed in the kitchen, in the kitchens of the board and cares, and take no part in household chores. Finally, they had something to offer. Everyone was telling the story of Abby and Renee and the murder. Families. I like to meet with families of my psychotic patients. They are the ones who spend enormous amounts of time caring for their disabled children. They know how their kids are doing better than anyone else. Perhaps for this reason, families are kept away from inpatient settings and especially from writ hearings, which are meant to break a 51 hold. These hearings are held in the hospital, set up without notice to families. They include a judge, the patient, and someone representing the hospital. They are nearly always successful, meaning that the patient is discharged immediately, without notice to the family. The patient wanders away, suddenly homeless. Parents are shooed away from the ward if they come to see the child or talk to the staff. Hospitals claim it would violate the patient's rights to have the parents come in the ward. To justify this, they cite HIPAA, the Health Insurance Portability and Accountability Act. In fact, it doesn't violate HIPAA for hospitals to let parents in to see their kids. HIPAA is concerned with confidentiality of patient information, but it does not forbid hospital staff from listening to parents or others with information. If the child is present for the meeting and doesn't object, staff can explain things like treatment plan, progress. It's not HIPAA, it's the freedom of hospital personnel to discharge patients long before they're ready, to free up beds. Inviting parents in to listen gets in the way of this freedom. The good news is that some of our patients get well enough to have a meaningful life. George, for example, takes care of his two boys. I always ask about his kids to see his face light up. One day he said, "My older boy is getting all A's, except for a C in Mandarin." Mandarin? Then we laughed together. He said, "I'm 90% normal. The neighbors don't know there's anything wrong with me." I said, "That's so wonderful, but I have to ask you about that 10%. He tells me about his ongoing hallucinations, which are cruel. They say, "Your mother's going to die and you'll lose your kids," or "Your leg's going to fall off." He has diabetes and takes proper care of himself, but that possibility haunts him. Still, he is 90% normal. I admire him for this. How do you do it? I ask. I take my meds, I see you, and I pray. Half an hour on my knees every night. Luther, another long-term patient, has a car, a bank account, and a job. He's always stayed on good terms with his family. He has a night job, but his sister leaves one of her windows unlocked, even when she's away, so he can come in if he's locked out at night. He is so normal and high functioning, I wonder if he's never actually been sick. So I do a deep dive into his past medical records. It turns out that he's had a drinking problem in the past and been flagrantly psychotic. He got better gradually. The last time we met, I told him I'd be leaving the clinic. Sorry I hadn't told him before. "I heard," he said. "How's it going with the drinking?" I asked. He said, "I drank 2 beers and walked out onto the street. There was a cop there." "What happened?" I asked. He said, "You've been drinking." I said, "Yes, I have." He paused. "So what happened after that?" I asked, wondering if this was bad news. He went one way and I went another. I loved his dry humor. I wanted to bring him back, do some test or something we'd have to follow up on, but there's nothing to do. He looked up at the faded Picasso on my wall. "In my family, we used to play Who's the Artist," he said. He knew the painting. "That's a Picasso," he said. "A really faded Picasso," I said. When there was nothing more to do, we said goodbye. Luther's not the kind of guy you hug goodbye, so he walked out and I sat down again. I should have gotten back to work, but I couldn't, not right then. Patrick, who OD'd. This happened at an FSP in Berkeley, where I worked briefly. I met a new patient, a tall, red-faced man with a hangdog manner. He was brought by his case manager, Brenda, who said, "He's just a little bit drunk today, so I could bring him." Then she turned on her heel and left. Patrick hung back outside my door till I invited him in. As he moved by me, I caught a whiff of alcohol in his breath. To my surprise, he looked me in the eye and said, "I bought a pint this morning, but I've been sipping it." I nodded. "What do you like to drink?" He looked surprised. Jim Beam, usually." I nodded, as if all my patients started their day with a pint of bourbon. "That pint you're sipping, will it last you all day?" He gave me a look, then shook his head. "Nope, I'll get another later." I wasn't shocked. I had had patients who drank a quart a day of hard alcohol. "So what else?" I asked. "Street drugs?" Usually I had to run through a few possibilities before people felt comfortable telling me about their drug use. But Patrick didn't hesitate. "Heroin and fentanyl." He kept his eyes on my face. "I've already OD'd once and got rescued with Narcan." He was lucky. Narcan reverses the effect of those drugs. "So next time you might not be so lucky," I said. "I know," he said. "I'm on the waiting list for Walden House 360. The waiting list. Patrick needed something that day. I will always wish that I'd buttonholed Brenda, his case manager, to see if we could come up with a better plan. But I was new, and Brenda radiated hostility for reasons I couldn't understand. I assumed she'd done the best anyone could do, and I let it pass. Other counties provide an online directory of services available to the county, listing mental health care, substance abuse, and homelessness. If we'd had such a directory, this story would have ended. If we'd had such a directory, this story would have ended differently. It was 6 weeks later when I heard the news. Patrick had OD'd again, and this time not gotten rescued. When I tried to pull up his record so we could figure out what had happened, it was gone, already erased from the system. I'm still thinking about that day, how we could have done better. I discovered that Walden House 360 had nothing in the East Bay except an Asian health clinic in Fremont. But Options Recovery was a 20-minute drive from our clinic. Patrick could have gotten treatment that day. They would have given him methadone or Suboxone, either of which would have prevented him from going into heroin withdrawal and bought time for him to begin recovery. They would have given him Valium or Librium to prevent complications of alcohol withdrawal, such as DTs. But it wasn't until much later that I found out about Options Recovery. That day, I simply turned in my resignation and left. So this is about the question of hospital treatment. In 2021, Disability Rights California, the DRC, filed a lawsuit against Alameda County Behavioral Health, alleging that it was mistreating its disabled citizens who suffered from severe mental illness. It relies too heavily on institutional care for this population, the DRC wrote. Federal law requires disabled people to be cared for in the least restricted setting. Hospitals are institutions which, for the purpose of disability law, are not in the community. The DRC was crusading to end hospital care for our patients, although this had nearly been accomplished already. The 1965 IMD exclusion and 16-bed rule had resulted in the loss of all but 10% of our beds for this population. I find it ironic that these professional disability lawyers fight to maintain the status quo, a system that leaves their clients disabled for life and often truly institutionalized behind bars. But the DRC lawsuit was celebrated, making headline news across the nation. In 2022, I attended a meeting with the DRC, a lawyer for the Justice Department, which joined the lawsuit, and a group of mothers. The Justice Department lawyer told us that avoiding institutional care was the most important goal. Gentle, consistent persuasion, she told us, was all that was needed to get these folks into treatment. Present at the meeting were a number of family advocates, mothers whose adult children had lived with untreated SMI, serious mental illness, for years. They begged for more beds. They knew from bitter experience that their children have no idea they're ill and that this lack of self-awareness is part of the illness. One by one, they described their children's desperate straits, those that had survived so far. Sons and daughters on the streets, homeless for years, often self-medicating with meth, fentanyl, and other street drugs. Mothers dreading the phone call that would notify them of their child's death. After each one spoke, the DOJ lawyer said, "I feel your pain," and repeated herself about gentle persuasion. Sometimes these mothers feared for their own safety as well. Many slept behind locked doors. Katie Poloni, an in-home outreach worker, helps her clients draw up a safety plan for use if necessary. Keep your phone with you at all times. Lock your bedroom door. Put away the knives or other potential weapons. Make sure you can exit a room. Don't get trapped. Alert the neighbors of the situation and recruit them as allies. Encourage them to call 911. Be proactive. Many cruelties heaped on these mothers is blame for their children's illness, a common myth with no basis in fact. Poloni tells them, "You are not to blame. There's no shame and you are not alone." Often her words bring tears of relief. Okay, that's the end. Any thoughts, questions?
Yeah. So I found your most helpful part. I mean, I needed to have all the case studies and everything else before, but your epilogue, which was the suggestions for change, that's just a page plus long, 12, sort of a 12-step program
Yeah,
of, of how to fix some of these problems.
yeah,
And I was feeling like maybe being an advocate, I think a lot of people, like those well-meaning people in the Justice Department, don't have any experience. They're
yeah.
going on some theoretical idea.
Mhm.
And what I'm reminded of is I was working as a volunteer with a program in Chico, which everybody thinks is really a great idea. But what I found out as a volunteer is that it outgrew in size um, what it was doing and got a bunch of grants and then didn't know what to do. And so it's not working out well. And the chat houses, it's Chico Housing Action Team. It was started by some lawyers actually who just wanted to get people off the streets. And I think part of the problem is sometimes when you take that housing first as your only
Yes.
goal, so they got the people off the streets. And the caseworkers are usually brand new graduates from Chico State, and they have no experience and they have no training in serious mental problems. And so what you do is you take 6 non-functional people and stick them in one house where they're a danger to themselves and each other. They are freed up because they have free housing. They can spend all their money on drugs and alcohol. And they have leases, but the people who are they have rules that they have to follow, but there isn't any follow-up. I mean, somebody can be selling drugs. They can be operating a business. They can be bringing other homeless people in for to spend the night, but trading drugs with them. You know what I mean? There's all this
Right.
stuff
Yeah.
going on. It's very destructive. And I would talk to them and talk to them and talk to them, and they'd say, well, but at least they're off the street, you know.
Mhm.
And, and that was it. So I was feeling really encouraged because I've never been able to figure out what to do. But you have a very clear list there of what to do.
Yeah.
And it involves making over a lot of institutions and laws and challenging things. But I sort of feel like I want to choose one or two of the low-hanging fruit and go after them.
Uh-huh. Great, great, great.
Yeah, I, I'm with Les. I think that your list at the end is extremely helpful in terms of an idealized system. You know, what pieces we need to change. But right now, I feel as if, you know. So I live in Yolo County, right? We have county mental health. Davis has actually, at least for some time, had a part-time social worker mental health person on the police force. So in principle, if you call the cops, you can get someone with mental health experience in social work to try to coordinate things. The university makes us all faculty go through all sorts of training. And if you think about it, we have, you know, what, 40,000 people at precisely the age where psychotic breaks occur and where catching people early is really important.
Yes.
And yet they're not terribly coordinated. And I can think of, you know, examples where I've seen students who came and, you know, were in the shelter, the homeless shelter, and clearly had issues, but there wasn't, eventually got sorted out and got treatment and is doing better. But, you know, for like maybe a year, there didn't seem to be any coordination. And then there's the sad case of the young student who was quite obviously becoming schizophrenic, and people around recognized that he was having trouble, and then he went out and stabbed and murdered two people, one of whom was a friend of mine from the homeless shelter, and nearly killed a third person, a woman who was homeless. And I'm thinking, you know, how do we miss this?
Yeah.
When his housemates, his professors, they knew enough that they basically kicked him out of school. They said, you know, you're not functioning. But how do we manage to quit on people, give up, let them slide? And then you have things, and now he's under treatment, and he's undergo his first trial ended in a he was found innocent of first degree murder, hung jury on second degree. He's now being tried for supposedly whether he is mentally competent or whether it was sorry, not guilty by reason of insanity. Dan was almost on the jury and fortunately was excused. I'm sure my knowing one of the victims would not have contributed to uh, a good. But how can we get better and being more aware at this early intervention here, right here, you know, in this county where we have all these young people and we're missing things, and we don't have the coordination. Um, One of my Quaker friends lost two brothers. Well, one to suicide, schizophrenia, and the other one, I, I don't, I think he eventually died. But her family started two residential treatment houses here, specifically for mental health, because again, there wasn't, and they've been taken over by the county, I think, at this point. But what can we do, and how can our university, for example, do better? We get all this training, and yet we miss the obvious.
Yeah. Yeah. Well, I
Laura, it
agree with
doesn't sound
everything
like
you
you
said.
missed it. It sounds like they knew what was happening and they didn't know what to do. Like
Yeah.
they didn't know.
No, they knew Alice Dominguez was dysfunctional,
Yeah.
too dysfunctional to be at the university. His roommates knew there was something really wrong. His girlfriend had broken up with him at some point along this process. But what, I don't know, you know, and this is where things seem to me to be lost. That people can see there's something wrong. We're trained to watch for this. We go through all this training, and
Mhm.
all the signs that you list, we're supposed to watch for.
Mhm.
And then there's this gap that what do? You kick them out of the university? Like, okay, great. That really solves it, doesn't it?
Right. Well, I mean, I just want to say, I think that part of it, I mean, there's a lot of parts to it. One is ignorance. People just don't know. And one is the kind of religious conviction that you should never ever put anyone in a hospital. And I'm just amazed by how universal that is. And yet I think probably that's what you'd have to do with these people, like, the one you mentioned. But we don't have enough hospitals, for one thing. And there really is a strong feeling that that's just simply rude. That's wrong. It's cruel. As if it's not cruel to leave people untreated, you know?
Well,
Anyway,
at least with Dan's younger brother, who I mentioned, being in the VA outpatient, I mean, inpatient care for 3 or 4 days, or they rebalance the medications, they get a sense of what's going on, they check everything, and then he's better for a long time.
right, right,
Trying to
right.
on an outpatient basis.
Yeah. But people think of inpatient psych care as cuckoo's nest, cruel.
Well, Alice, there's one thing I know we're running out of time, but just very quickly with the experience with my young friend who was, I'm beginning to think, upcoded to schizophrenia. I
Hmm.
don't think necessarily his is a remarkable recovery. I think he doesn't have schizophrenia. But he was in Napa. He did attack somebody with a knife. He was in Napa for quite a while. They didn't really have a good program for him. As I said, it was all 12-step. That was their answer to everything. But when he got out, he was sent to Conrep. Are you familiar with Conrep?
No.
Okay, so it's a money-making thing. They're privately owned, but it's the requirement when you leave Napa. You have to go into Conrep. And it is like Cuckoo's Nest in that they're making money, so they try very hard never to let you leave. And it's in private board and care homes, and it took a lawyer and a big lawsuit to get him released from that program after many years.
Wow.
And it wasn't providing anything except 12 step. That's what it was. In fact, to the extent that this young guy who doesn't have a clear understanding of the reality of his abilities, wrote a bunch of books which he published on Amazon and has lots of likes and sells these little pamphlets about everything he learned from the 12-step program. So anyway, I just want to say Conrep is one of the things to investigate as well.
Yeah, 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 yeah. Well, I'd like to investigate uh, the, yeah, yeah.
Plus, to me, you describe a very brutal world. And I'm wondering, how do you keep your spirits up?
Hmm. Well, um, I have friends. I have a great family, one of who is sitting here. Uh, and I think it's important work. I like listening. I like this. I mean, I like to do this work. I chose it on purpose because I enjoy it. I like to listen to people. And, most of the time it's not all terrible, you know.
Mhm.
It's just,
I did have one more question though,
yeah.
because what you're describing of how psychiatrists are often becoming people who spend all their time clearing people for disability or signing off on prescriptions.
Mhm.
Are in the new medical graduates, are very many people going into psychiatry? Because there's no psychiatrist in the entire Butte County. There isn't one.
Yeah, yeah.
So,
Same
so
with Humboldt County, I think. Um, yeah. Uh, well, I think that we should follow all the 12 steps. We should educate everybody in mental health on serious mental illness. We should drop the IMD exclusion. We should rebuild hospitals. We should, on and on. Yeah.
and
I
maybe
think the question was, are medical school graduates going into psychiatry. That was part of it.
Oh, sorry. Um, I don't know. I don't think very many, but people aren't, medicine is not as attractive as it used to be. I mean, if you're smart, you become a programmer, I guess. I don't know. That's kind of a downer. Uh, yeah. Any other thoughts or questions? Okay. Well,
Well, if anybody finds out anything, I don't know anything about how politics work in Sacramento. If you wanted to talk to somebody about some of these issues and present them with information, I
mhm.
need to find out who do you see, how do you go about it. So if anybody wants to share any information about that later or by email, that would be cool.
Okay, right.
Alice does work now with several organizations that are trying to make changes, trying to keep beds open, trying to get the IMD exclusion uh,
Cancel.
reversed, and trying to get the authorities to allow families to have more involvement
Right,
in treatment.
right. Yeah, there's
And
several.
also trying to get, I don't know if you mentioned this, Alice, but I found it amazing that psychiatric training usually does not involve any uh, education about serious mental illness.
Really?
I found this answer to my question. It
Okay.
says medical school students are going into psychiatry about 7 to 8%, double of what it was 20 years ago. So where are they?
They're in the Bay Area, I guess.
Okay.
Yeah.
Well, thank you very much, Alice. I
Well,
really,
thank you.
I'm lending my book to my neighbor who's a semi-retired pediatrician, but she says most of her work now is in more psychiatric issues with young kids. So she wanted to borrow it.
Great. Wonderful. I should have probably finished this talk with reading the 12, basic recommendations. One is single payer. We should have single payer, absolutely, all over.
So for what it's worth, I put in the chat a link to someone I know who's Kieran Savage Sangwan, who's the director of the California Pan Ethnic Health Network, and is particularly interested in mental health and is pretty prominent. She's the daughter of a good friend, and
Great, great.
she was
Alice,
told.
what does IMD stand for again? I forgotten.
Institute for Mental Disease. Yeah. So if you have a facility like that, or even a ward like that, and it has more than 16 beds, you can't use Medicaid. I mean, that's ridiculous. That's ridiculous. So
Uh, Two things. What is IMD? Is it a government thing or is it NGO? And secondly, what's the reason for the rationale behind that 16 bed limitation?
oh, well, the reason that, well, it was in 1965, and it was passed by Congress along with the creation of Medicaid. They were afraid that the uh, the big psych hospitals would just swallow up all this new benefit, and they decided that, you know 16 beds was enough, and that anything larger was wiped out all the Medicaid. They
I
weren't
don't
able to.
hear a rationale there. Uh, I just hear, let's not let them get so they're expensive. I mean, what is the rationale?
Money.
Money, yeah. And also, it was a time, I mean, I can't, I think everybody in the world must have seen Cuckoo's Nest, which just presents inpatient psych hospitals as just these torture chambers. People still think that ECT is, like it's shown in that movie. It's not, but the city of Berkeley outlawed ECT after that came out. It's just a lot of ignorance. Did I answer your question? I've sort of wandering.
It was a good wander.
I expect that there's not a very good rationale other than this is too expensive.
Yeah, I think, well, they were afraid. Although, it's the irony is that if you don't treat serious mental illness, it leads to all kinds of problems that we are paying for,
Yeah,
homeless
exactly, of
care,
course.
jail care,
Mm.
multiple hospital visits. It's very expensive to have people untreated.
You know,
Hospitals are closing all over the place in rural areas.
right.
Yeah,
We've had
yeah.
hospitals close north of Pittsfield here in this area.
It is true though. I mean, I'm not defending the IMD exclusion by any means, but I think Congress is aware of what happens when a field opens up where you can get reimbursement. And two examples that have come up that have happened that probably everybody knows about are um, the drug detox, these centers that started opening all over the country, and because they could get reimbursement for the treatment, and so they start opening these detox centers and for profit. And the other example, which is just recently, is something that everybody thought was great, I think, hospice care. Um, that hospice is better than hospitalizing people who are terminal, and it can be great. But then all this money became available for hospice, and there's this scandal around the country that there's these for-profit hospice centers that are signing people up and getting people in there, even though if they don't have a terminal illness. They stay in hospice care for this extended period of time, and these for-profit hospice centers are making a killing. And so I think they thought back in 65, oh wow, if we make this benefit available, to any mental health treatment, they'll just open up these huge mental health centers and they'll take all the money.
Well,
So I mean,
they already had them, there were state hospitals that were large, that thousands of people.
right.
Um, so, yeah.
But there was
Okay,
no medical justification, as Tony was asking for. There was no reason this is a bad idea, so we won't fund it. It'll take all the money.
Yeah,
okay.
yeah.
Uh, okay, next time we're going to have Fred, if I'm not mistaken, talking about his uh, case that I don't understand. It's about that went to the Supreme Court, Fred?
Yes, I put a title for the talk because I thought it was so great. I found an article that was about the whole case and the whole thing that was going on. And it's called pedicle screws, and I'll explain it briefly what pedicle screws are. But the name of the article was "The Blaming of the Screw," which I
Pretty good.
which I thought was pretty good. But yeah, I think it's an interesting story. It has a lot of twists and turns and funny things that happened along the way that got us to the Supreme Court.
All right, and all the rest of you guys are, I know, hard at work on thinking of something to give a presentation on. So I'll be on your case to do that. And otherwise, I'm gonna uh, quit the recording, and we'll see you next time.
Okay.
All right.
Thank you,
Thank you,
Alice.
Alice.
Thank you.